opportunity because the time is short, and initially we were told that this is going to be an hour and 30 minutes, but it was truncated to 55 minutes. I'm just going to be talking about two entities and hopefully talk about them in detail. One is a multi-layered PED and the other is FIPED. So it's just those two because otherwise I can't cram things in in that time. So multi-layered PED. Just going to start with the case and then hopefully kind of compress the findings together at the end. So 47-year-old male presented with sudden onset of metamorphopsia in the left eye since 5 days and a gradual decline in both eye vision since 2 months, since August 17, long time back. That's the right eye, that's the left eye, typical vascularized PED, both the eyes. There is a precordial cleft, as you can see. I don't know whether there as well, and there's fluid sub and intraretinal in both the eyes. Both the eyes were treated. The right eye, unfortunately, after a couple of ranibizumab monthly injections, the patient was scheduled to receive the third one, but just 10 days prior to having received, having been scheduled for the third injection, actually ripped, and the acuity actually dropped a bit, and you can see the rip there, and that was unfortunate. The left eye was being treated as you would regularly. The right eye also then subsequently went on to develop a massive submacular hemorrhage. I could not retrieve the Optos ultra wide field, but trust me, it was extending to the aura in two quadrants and up to the equator in the other two. And we did try and suggest surgery to the patient, and weighing the pros and the cons, the patient refused any intervention in the right eye. So now essentially a monoocular patient. We suggested at that point in time that we should be switching from ranibizumab to aflibercept, since despite 2 monthly ranibizumab injections, the right eye had gone down the route that it did, and that's what we did. The patient continued to receive once being shifted on aflibercept injections. June 18, you can see the change in morphology. You can also see the change in morphology of the PED from the outset. You can now see that instead of the at the outset, when you had those vertical lines, you now have these hyper reflective and hyporeflective alternate kind of lines which are going all through, which kind of also mirrors the clinical appearance. It was more orange to look at when it was treatment naive. It's now a little more orangish yellow. And you can see that patient was fairly well controlled on aflibercept, ended up needing about 3 aflibercept injections a year. The octa is showing that complex at the base. This is 5 years follow up, and now it's your typical garden variety multi-layered PED, which is tight, which is compact, which has lot alternate hyper and hyporeflective vertical lines which are parallel to the retinal pigment epithelium. May or may not be associated with the precordial cleft. It was at the outset when it began, but with treatment these can tend to collapse as it did. And some people have looked at a precordial cleft maybe being indication for treatment and also having some prognostic significance. So just to quickly sum up multi-layered PD, a relatively recently established labeled entity. It generally signifies a more stable clinical course down the line, and generally the visual acuity can be fairly well preserved at the level that the multi-layered PED patient presents with SRF. It also indicates a couple of good prognostic signs, as in once you get the multi-layering, the chances of a RPE rip or a massive submacular hemorrhage, both of which unfortunately happened in the fellow eye of this patient, are considerably lower. And typically, so this patient got the multi-layering after 2 ranibizumab and 6 aflibercept injections. So it also, if a patient just walks into you also know if a patient has a multi-layered PED, although you could get this de novo, but it's much more commoner to get this down the line once the patient has been chronically treated with anti-VEGF. So that is your multi-layered PED. Coming to FIPED, which is flat irregular pigment epithelial detachments. I don't know how much time I have, we'll see. So flat, I think it's self-explanatory what it means. It's flat, it's irregular, it's a pigment epithelial detachment. So flat means it has to be low, and so the height less than 100 microns, at the max anywhere, and at least 500 microns going, in the extent. So it could be 500, 1000, 1500, but it has to be at least 500 microns the extent that way. And because it's flat, it has to be low, so not more than 100 microns, right? It could be vascular, it could be avascular. I'm just going to show you quickly both examples, time permitting, and see how both of them differ and whatever similar. And because this is AMD, I'm just talking about 5-pid in AMD and not CSC and other things. Again, elderly males had sudden loss of vision secondary to AMD. The left eye, that's an artifact. I apologize. That's also the same blown up image. You can see multiple drusen's. Clinically looked okay. That's the radial OCT going all through, and you can see there's no sub or intraretinal fluid. However, you can see these, right? They're almost, so that is so the multiple pigment epithelial detachments, they aren't high, but they're kind of spread all over. It's like almost like spilling a glass of water on the floor. It'll actually flow and be a lot much more in horizontal extent than vertical extent. uh, One-eyed patient, the other eye had that. I'm going to finish in half a minute. This patient had a nascent, MNV, sitting right beneath the the RP, and you can see it was co-localizing to that area. What happened to this patient, I'm not talking about, but that is one thing that you can, a vascular fiped can point to that. The other, which is the avascular, again, this patient had shallow irregular pigment epithelial detachments all there. I just want you to concentrate on the right eye. Was asymptomatic all throughout, but had this shallow drape of subretinal fluid beginning in 2016. Imaging, both fluorescein, ICG, as well as Octa showed no membrane, no evidence of any activity. And again, please just concentrate on the right eye for this. This is 1 year follow up. That shallow drape of fluid remained the same. The fiped actually elongated horizontally a bit, but again was observed. Again, this is 2 years down the line. The SRF is persisting. This is again 3 years down the line. Repeat FAICG, Octa not showing anything. The SRF is persisting. The acuity is maintained. Patient was lost to follow up 2.5 years due to the COVID pandemic. Came back a total follow up of 6 years. October 2022. The angio was repeated. You can see that although the the drusen's have become a little more confluent, there is the acuity is maintained. There's a sliver of SRF. So what I basically want to say is that avascular fiped can still have some fluid, and that is one of the cases in which you might have what we now know as what looks to be exudation but is non-neovascular. So if you have if you have fiped, it is avascular, clinical exam and on OCT and on Octa, and you can't demonstrate a membrane. The subretinal fluid is there. It will remain like that for a long time and does not need treatment, needs observation. I wouldn't even say close observation. I'd say 3 to 4 monthly apart observation, as this case showed that 6 months for 6 years follow up remain the same. The acuity is the same. So vascular, rule out a type 1 MNV. Avascular, rule out. I mean, you should try and keep in mind non-exudative AMD. Thank you.
Thank you, Mohit.
Sorry, I didn't overtalk.
I probably just would have one comment that
Yep.
a lot of the pictures that you showed looked very typical of a neovascular network in PCV and confluence of drusen in AMD. I think typically we reserve FIPED for the entity associated with CSCR when we see that little ripple and you're not sure is there neovascularization or not. So probably, maybe since this is acronyms, we would probably ignore the ones where you have these confluent routes and where everything is homogeneous. And I think at that point we are not really worried about whether it's neovascularization or not.
Fair enough, ma'am. I
Anyone?
actually, I totally agree, ma'am. But because I was put in the AMD group, acronyms in the AMD, I wanted to try and showcase which are those,
Yeah,
and that's
but
why at the
they're
outset I
very
said I'm not
nice,
talking about CSC, ma'am. But fair enough,
very
absolutely agree,
nice
absolutely agree.
cases. Thank you. Does while Bhavik gets his talk up, anyone has a comment or
Excuse
a
me,
question?
excuse me.
Yes, Shane.
Drusenoid exudative detachment. That's a new entity which we all been talking about.
Yes.
Can you explain a little further on it? I'm still not clear on the idea. Is it is it an extensive form of drusenoid PED which we are talking about earlier? or is it like a flat drusenoid PD with a little SRF above it, as what you showed?
No.
No.
So the SRF will generally not be there.
So I just want.
I think you're talking about the cap of fluid on top of a
Absolutely.
PD.
So there's an
Yes.
entity which is being recently described
Yeah.
as a drusenoid exudative detachment of the macula.
Yeah. So that's so
I'm just trying to
yeah.
get things
So
straight.
that is
Yeah.
exudative non-neovascular AMD, in which you see have exudation seen on the cross-sectional OCT, but it'll not be intraretinal fluid. It'll be subretinal fluid, and you can get it in three kind of different scenarios. So one is if you have a large TENS PED, like you can get it, at the top, like a cap on top. You can also get what might appear like SRF at the junction where that large blister joins the retina because of a geographical effect. So the edges, the top, and the third is the one that I showed, in which you have flat irregular PEDs, low lying PEDs, and you have a shallow drape of SRF over it.
All these are called exudative drusenoid.
Well, no, well, they aren't called anything, but that's what the paper and that's what Dr. Bailey's work and actually labels them as, because I think it's the easiest to understand that way. They're exudative because you see exudation on OCT, but they are non-neovascular because if you do FA, ICG, and or OCTA, you are not able to demonstrate a membrane. So it's non-neovascular, but there is exudation. So it's not related. So it's not.
In the form of subretinal fluid.
Yes, in the form of subretinal fluid. If you see intraretinal fluid, then it's not this, because then it's
exudates beneath the fovea. That's not what we are looking at. It's
no,
just
no.
flowing,
So
yeah.
no, so not exudation as in diabetic retinopathy. Exudation as in the form of a subretinal fluid seen on cross-sectional OCT.
So something similar to what you just showed.
Yes.